Hi, welcome to part 3 and let's read the hormonal response. Hormonal response. The stress response includes activation of ANS as discussed previously in the afferent signals section, as well as activation of the hypothalamic pituitary adrenal axis. Shock stimulates the hypothalamus to release corticotropin releasing hormone, which results in the release of adrenocorticotropic hormone or ACTH by the pituitary. ACTH subsequently stimulates the adrenal cortex to release cortisol. So the cortisol acts synergistically with epinephrine and glucagon to induce a catabolic state. Cortisol stimulates gluconeogenesis, insulin resistance, resulting in hyperglycemia as well as muscle cell protein breakdown and lipolysis to provide substrates for hepatic gluconeogenesis. Cortisol causes retention of sodium and water by the nephrons of the kidney. In the setting of severe hypovolemia, ACTH secretion occurs independently of cortisol negative feedback inhibition. The RAAS or the renin-angiotensin system is activated in shock. Decreased renal artery perfusion, beta-adrenergic stimulation, and increased renal tubular sodium concentration cause the release of renin from juxtaglomerular cells. Renin catalyzes the conversion of angiotensin produced by the liver to angiotensin 1, which is then converted to angiotensin 2 by the angiotensin converting enzyme, or the ACE, produced in the lung. While angiotensin 1 has no significant functional activity, angiotensin 2 is a potent vasoconstrictor of both splanchnic and peripheral vascular beds and also stimulates the secretion of aldosterone, ACTH, and ADH, or the antidiuretic hormone. Aldosterone, a mineralocorticoid, acts on a nephron to promote reabsorption of sodium and a consequence, water. Potassium and hydrogen ions are lost in the urine in exchange for sodium. The pituitary also releases vasopressin or ADH in response to hypovolemia, changes in circulating blood volume sensed by baroreceptors and left atrial stretch receptors, and increased plasma osmolality detected by the hypothalamic osmoreceptors. Epinephrine, angiotensin 2, pain, and hyperglycemia increase production of ADH. ADH levels remain elevated for about 1 week after the initial insult, depending on the severity and persistence of the hemodynamic abnormalities. ADH acts on the distal tubule and collecting duct on the nephron to increase water permeability, decrease water and sodium losses, and preserve intravascular volume. Also known as arginine vasopressin, ADH acts as a potent mesenteric vasoconstrictor, shunting circulating blood away from the splanchnic organs during hypovolemia. This may contribute to the intestinal ischemia and predispose to intestinal mucosal barrier dysfunction in the shock states. Vasopressin also increases hepatic gluconeogenesis and increases hepatic glycolysis. In septic states, endotoxin directly stimulates arginine vasopressin secretion and independently of blood pressure, osmotic, or intravascular volume changes. Pro-inflammatory cytokines also contribute to arginine vasopressin release. Interestingly, patients on chronic therapy with ACE inhibitors are more at risk of developing hypotension and vasodilatory shock with open heart surgery. Low plasma levels of arginine vasopressin were confirmed in these patients. Okay, that's it for the afferent signals. Next is circulatory homeostasis. First is the preload. Preload. At rest, the majority of blood volume is within the venous system. Venous return to the heart generates ventricular and diastolic wall tension, a major determinant of cardiac output. Again, venous return is the major determinant of cardiac output. Gravitational shifts in blood volume redistribution are quickly corrected by alterations in venous capacity. With decreased arteriolar inflow, there is active contraction of the venous smooth muscle and passive elastic recoil in the thin-walled systemic veins. This increases venous return to the heart, thus maintaining ventricular filling. Most alterations in cardiac output in normal heart are related to changes in preload. Increases in sympathetic tone have a minor effect on skeletal muscle beds but produce a dramatic reduction in splanchnic blood volume, which normally holds 20% of the blood volume. Again, the splanchnic blood volume holds 20% of the blood volume. The normal circulating blood volume is maintained within narrow limits by the kidney's ability to manage salt and water balance with external losses by systemic and local hemodynamic changes and hormonal effects of renin, angiotensin, and ADH. These relatively slow responses maintain preload by altering circulating blood volume. Acute responses to intravascular volume include changes in venous tone, systemic vascular resistance, and intrathoracic pressure, with a slower hormonal change less important in the early response to volume loss. Furthermore, the net effect of preload on cardiac output is influenced by cardiac determinants of ventricular function, which include coordinated atrial activity and tachycardia. That's it for preload. Next, ventricular contraction. Ventricular contraction. The Frank-Starling curve describes the force of ventricular contraction as a function of its preload. This relationship is based on force of contraction being determined by initial muscle length. Intrinsic cardiac disease will shift the Frank-Starling curve and alter mechanical performance of the heart. In addition, cardiac dysfunction has been demonstrated experimentally in burns and in hemorrhagic, traumatic, and septic shock. That's it for ventricular contraction. Next, afterload. Afterload is the force that resists myocardial work during contraction. Arterial pressure is the major component of afterload, influencing the ejection fraction. This vascular resistance determines precapillary smooth muscle sphincters. Blood viscosity also will increase vascular resistance. As afterload increases in the normal heart, stroke volume can be maintained by increases in preload. In shock, with decreased circulating blood volume and therefore diminished preload. This compensatory mechanism to sustain cardiac output is impeded. The stress response with acute release of catecholamines and sympathetic nerve activity in the heart increases contractility and heart rate. That's it for afterload. Next, microcirculation. The microvascular circulation plays an integral role in regulating cellular perfusion and is significantly influenced in response to shock. The microvascular bed is innervated by sympathetic nervous system and has a profound effect on the larger arterioles. Following hemorrhage, larger arterioles vasoconstrict. However, in the setting of sepsis or neurogenic shock, these vessels do not vasoconstrict but vasodilate. Additionally, a host other vasoactive proteins including vasopressin, angiotensin II, and endothelin-1 also lead to vasoconstriction to limit organ perfusion to organs such as skin, skeletal muscles, kidneys, and GI tract to preserve perfusion of the myocardium and the CNS. Flow in the capillary bed is heterogeneous in shock states, which likely is secondary to multiple local mechanisms including endothelial cell swelling, dysfunction, and activation marked by recruitment of leukocytes and platelets. Together, these mechanisms lead to diminished capillary perfusion that may persist after resuscitation. In hemorrhagic shock, correction of the hemodynamic parameters and restoration of oxygen delivery generally leads to restoration of tissue oxygen consumption and oxygen levels. In contrast, regional tissue dysoxia often persists in sepsis. despite similar restoration of hemodynamics and oxygen delivery. Whether this defect in oxygen extraction in sepsis is the result of heterogeneous impairment of microcirculation, or they call it intraparenchymal shunting, or impaired tissue parenchymal cell oxidative phosphorylation and oxygen consumption by the mitochondria is not resolved. Interesting data suggests that in sepsis, the response to limit oxygen consumption by the tissue parenchymal cells is an adaptive response to inflammatory signaling and decreased perfusion. An additional pathophysiologic response of the microcirculatory and microcirculation to shock is failure of the integrity of the endothelium of the microcirculation and development of capillary leak, intracellular swelling, and development of an extracellular fluid deficit. Seminal work by Shires helped to define phenomenon. There is decreased capillary hydrostatic pressure secondary to changes in blood flow and increased cellular uptake of fluid. The result is a loss of extracellular fluid volume. The cause of intracellular swelling is multifactorial, but dysfunction of energy-dependent mechanisms such as active transport by the sodium-potassium pump contributes to loss of membrane integrity. Capillary dysfunction also occurs secondary to activation of endothelial cells by circulating inflammatory mediators generated in septic and traumatic shock. This exacerbates endothelial swelling and capillary leak, as well as increases leukocyte adherence. This results in capillary occlusion, which may persist after resuscitation and is termed no reflow. Further ischemic injury ensues, as well as release of inflammatory cytokines to compound tissue injury. Experimental models have shown that neutrophil depletion in animals subjected to hemorrhagic shock produces fewer capillaries with no reflow and lower mortality. So that's it for this part, and I would like to summarize. For the circulatory hemostasis, we have preload, ventricular contraction, afterload, microcirculation. So that's it for the circulatory hemostasis.